Hello, everyone. Welcome to our fourth virtual journal club. My name's Jiggy. If you haven't seen me before, I'm on the NANSIG committee. I'm the social media and website lead, and I'm just filling in for Robin during this. So today we'll be discussing the paper titled Neurological and Neuropsychiatric Complications of COVID-19 in 153 patients, a UK-wide surveillance study. And this paper was published in the Lancet Psychiatry in late June. And so before I actually hand this over, I'd like to promote eBrain quickly, who are helping us with this talk. So eBrain, you've probably heard about it before. It's a brilliant online resource, and they're actually providing kind of, the Zoom account and everything. So we thought it would be a good opportunity to talk about it. They have a bunch of resources. So they have like e-learning, they have MCQs, virtual patients. So if you're really interested in neurosurgery or neurology, definitely check them out. You can actually get an annual membership for £10 just for a year by being a NANSIG member for free. So that's pretty cool. But I'm not going to plug anymore because it's embarrassing. But anyway, I'm delighted to introduce Dr. Varatharaj, the lead author of this paper. So he studied medicine at Oxford before training in Liverpool and London. He then moved to Southampton in 2014 as a specialist reg in neurology. After completing an NIH academic clinical fellowship, he now holds an MRC clinical research training fellowship. And he's also a key part of the Coro Nerve Studies group, which if you read the paper we're talking about today, you'll know that they coordinate national surveillance for the complications of the pandemic. So that's very cool. So thank you very much for listening to me. If you have any questions for the Q&A, pop them in the Zoom chat. You can send them publicly or privately to me, or you can tweet us at NANSIG1. So thank you so much, and I'll hand it over. Thank you.
Thank you very much, Jiggy. Thanks for the introduction. Thanks for having me. The slides coming through okay?
That's perfect.
Great. Yeah, so my name is Varatharaj. I'm a MRC Fellow in Neurology Registrar in Southampton. And I'm going to talk about the possible neurological complications of COVID-19. So I'm going to start by saying why this topic is important and relevant for us. I'm going to describe how we've begun to study this in a UK nationwide surveillance program. I'm going to tell you the early results of our surveillance. And then I'm going to take a step back and tell you why I think it's important to say why, as scientists, we need to take these and other results with some caution. And then I'm going to describe where we plan to go next. And all of this work that I'm going to describe comes from the Coro Nerve Studies group, of which I'm part, which is a collaboration in the UK pulling together several universities and professional bodies in neuroscience. So first off, why is this important? Well, the obvious answer is that if there are significant neurological impacts of COVID, then this needs to be reflected in our service provision and in our research priorities. And even if these complications are rare as a proportion, this is a pandemic. Millions of people in the UK have probably already been infected, and that number is only going to go up. So the denominator of possible cases is large. I think there are three main specific reasons why, as neurologists, we should be interested in COVID. So there's biology. We already know that systemic infection can affect the nervous system. And this is something that Southampton has a real interest in. Research in Southampton has shown that cognitive decline in Alzheimer's disease, measured by a score here over time, accelerates faster in people who have systemic inflammatory events, usually infections, compared to those who don't. So this is a neurodegenerative process that can be accelerated by infections in the body. And Southampton research has also shown that systemic inflammatory signals can be communicated to the brain, to the healthy brain or the diseased brain, and activate and prime microglia, which can lead to sickness behavior and ultimately neuronal damage. And that process is amplified in neurodegenerative disease. And we already know in clinical practice that there are many clinical syndromes that we see where infection outside the CNS causes dysfunction in the CNS. Probably everybody here has experienced sickness behavior when they've had a common systemic infection, for example, flu. We all know what delirium is. Septic encephalopathy, you could argue, is a more severe form of the same syndrome. And we also recognize that there are syndromes that occur after a systemic inflammatory episode, like syndromes that occur after vaccination, after infections. And we also know that diseases, for example, multiple sclerosis, can experience relapses associated with infection. So sometimes these syndromes are para-infectious, perhaps due to metabolic derangement during infection, or the circulating effect of cytokines, or temporary disruption of the blood-brain barrier. And that's my particular interest, using an advanced quantitative MRI technique called DC-MRI to measure blood-brain barrier permeability. And sometimes these complications are post-infectious, thought to involve the initiation of an aberrant cellular or humoral immune response. Guillain-Barré syndrome or acute disseminated encephalomyelitis would be typical examples. And importantly, when I say neuroinflammation, I mean the cerebral vasculature as well as the parenchyma. And I think that's something that will be important for COVID. And the other thing that we know from clinical practice is that sometimes a CNS inflammatory process, which was apparently triggered by systemic inflammation, can take on a life of its own. I'm thinking here about often in MS, you might see an index episode where the relapse was followed a systemic infection, but then the disease takes on a life of its own. But a missing piece of the puzzle here is, how are these signals of systemic inflammation transferred to the CNS? How do signals cross the blood-brain barrier? So from a biological point of view, this pandemic provides a really unique opportunity to study this in a huge and varied population. And then there's the other side of things, which is where we need to ask ourselves, is this solely a systemic infection? Or is SARS-CoV-2 neurotropic? Does it get into and infect cells within the nervous system and cause a direct viral cytopathy? So we already know a long list of neurotropic viruses that cause encephalitis and other syndromes, and here's a non-exhaustive list. HSV1 is obviously a very common cause worldwide. Some of these other causes are much rarer. Some are geographically restricted. Some are worldwide. Some of these are viruses that usually cause a non-neurotropic syndrome. For example, influenza, in the vast majority of cases, doesn't cause an encephalitis, but they can sometimes enter the CNS. Coronaviruses aren't on this list. So there are many coronaviruses. These first four are human coronaviruses which circulate worldwide and are extremely common causes of upper respiratory tract infections. And there have been extremely rare reports of associated neurological disease with these viruses, mainly in children. And then there's SARS-CoV-1, which was SARS, which caused an outbreak in the Far East in 2002, 2003, and was confined. And out of about 8,000 cases of SARS, there were 3 case reports of virus in the CSF or brain tissue. And then there's MERS-CoV, the virus which causes MERS, Middle East Respiratory Syndrome, which emerged in the Middle East in 2012, and there have been sporadic outbreaks elsewhere since then. And out of about 2,000 cases worldwide of MERS, there have been 9 cases with a neurological complication, none with virus detected in the CNS. And then we've got SARS-CoV-2, currently circulating in a pandemic, for which we don't know. We don't know whether neurotropism is an important part of this virus's behavior. So far, there have been a handful of cases with SARS-CoV-2 reported in the CNS causing an encephalitis or meningoencephalitis. The first case had evidence of inflammation in the CSF, cells in the CSF, and evidence of temporal lobe inflammation on the MRI, which is quite compatible with an encephalitis. The second case reported in the literature didn't have CSF or brain imaging, but at post-mortem had evidence of virus in the frontal lobe, parenchyma, and endothelium, which I think is important, and this has fed into a lot of discussion about how the virus might enter the brain, if it does, because its target receptor is ACE2, the angiotensin-converting enzyme receptor, which is highly expressed in much of the endothelium, including in the cerebral vascular endothelium. And there's a third case in the UK, which hasn't been written up yet, but which we're working on. So I think the second reason, other than biology, that we should be interested in this is history. And I don't want to make too much of this because I don't think there's an absolutely clear parallel. But I don't know how many of you have seen the film Awakenings, which was obviously about people suffering post-encephalitic Parkinsonism in the 60s who were treated with levodopa when it was first introduced and experienced an awakening. But my only point here is that isn't it fascinating that in the 20th century, there was this new and devastating neurological illness, encephalitis lethargica, that swept the world at the same time as a pandemic of a new and devastating respiratory virus, the Spanish flu. And then it disappeared. We don't see this illness anymore. And a century on, we still don't know what caused it. Maybe it was an immune response against the basal ganglia, maybe not. It just makes the point that such things do happen. And if it happens again in this pandemic, we should be prepared. I'd really recommend this paper, which I think is a really excellent review about encephalitis lethargica, which is a fascinating syndrome. And then the third reason, as well as history and biology, that I think we should be interested in this is demand. The public are interested in this. Seems to be a popular belief that COVID-19 is somehow completely different to other respiratory viral infections. And I think it remains to be seen how true that is, but of course elements of it may be true. In terms of neurology, there's been this signal about stroke occurring with COVID-19, which so far actually the data coming in seems to support that idea rather than refute it. And like I mentioned, there's this flavor of COVID causing an endotheliopathy, which of course occurs in other infections, for example, mycoplasma or varicella zoster virus, but not on this scale, perhaps. Delirium has been a big problem with COVID. Obviously, a lot of the people hospitalized with COVID have been people who are older and have other comorbidities. It still hasn't been shown yet that the delirium in COVID is different in frequency or in character to how it is with any other infectious trigger. And then encephalitis has grabbed a lot of headlines, especially in relation to the idea that perhaps COVID enters the brain through the olfactory nerve, and whether that's related to anosmia that's been reported a lot. But like I say, there's only been a handful of cases reported where virus has actually been detected in the CNS. So I think what we need to do is respond to these things by adding data so that we can calmly deal with these questions which have been raised. So how do we do that? So really what we need is to gather real-time prospective data. If we wait for the peak and then work backwards, then we have the problem of trying to retrospectively gather case details from all over the country, which is very difficult. And then obviously that's subject to recall bias of clinicians. So what we very quickly did is set up the Coroner Studies group and set up a process for rapid case reporting during the initial pandemic phase. We quickly formed a nationwide collaboration between several universities, Southampton, Liverpool, Newcastle and UCL, and many professional bodies in neurosciences. And importantly, what we did from the start is we did not respect this artificial separation which exists between the brain and the mind. We linked neurology and psychiatry together from the start, as they should be. And as I'll show you in the data, I think that's very powerful. We very quickly built a simple web form to collect a minimum data set, which we purposefully kept extremely brief with a very clean interface so that busy clinicians could report cases very rapidly. And we created this graded case definition for COVID, recognizing that if you only include laboratory confirmed cases, then you're throwing away masses of useful data. And we leveraged the reach of these professional organizations to get this reporting portal out there and being used very quickly. And importantly, with this case definition, we allowed things to be grey. We recognize that people may see patients in whom they strongly suspect COVID, the symptoms match, the chest x-ray matches. We're during a pandemic, it's the most likely diagnosis, but they weren't able to be tested or the test was negative early on. It's important that we included those cases. So as a result of all this quick work, as the pandemic ramped up, this is Public Health England's reporting of nationwide cases in England. increasing exponentially in February, March and April. Here's when we had the idea, when I thought, what if wouldn't it be great if we could set up something like this? And within about a week, we'd managed to set up this website and we had cases coming in. So, and that's important because we needed to be set up as the numbers was climbing. No point here, it would have been too late. We would have been past the peak. And then with anything like this, there's always a judgment call as to when you cut the data and start analyzing it. On the one hand, you think, well, the more data I collect, I'll get a bigger sample and it'll be more representative. But on the other hand, there's no point just having data without it being used. And this is an evolving pandemic. And if there are early trends emerging which are important, then you need to get them out there so the data can be used to inform practice and inform policy. So we made an arbitrary decision early on that we'd cut the data at 150 cases and start analysing it. And actually we reached that in 3 weeks. We reached 150 cases. So then a couple of weeks later, we put this paper out, which is the paper that we're going to discuss. And this is the early data that's come out of this study. So the different portals started at different times, so the length of data collection differed. And you can see that the psychiatry portal was slightly later, which makes it all the more remarkable that actually we received many psychiatric reports. For each case with data on when the patient first presented, we examined how this evolved over time, where day 0 is the first UK case of COVID in total. And in the blue line, you can see Public Health England's reporting of how the pandemic evolved over February, March and April. And in red, you can see the cases reported to us when the patient admitted or was presented to hospital. So you can see that this exponential rise in COVID overall in the UK was mirrored in our rise in cases with neurological complications being reported. And that gives us some faith that our sample is fair. Here's the stratification of evidence of COVID that we used, where we said that confirmed cases were those where there was laboratory evidence, either PCR or antibody testing when that later became available. Probable were those with chest imaging, and possible were those with a clinical suspicion. And as you can see from this map, we had cases coming in from all over the UK with a clear bias towards big teaching hospitals in the big cities. So what sort of things were reported? What sort of neurological and neuropsychiatric complications did we see? Well, really there were 3 main categories. There was cerebrovascular disease, which was mainly ischemic stroke, but also hemorrhagic stroke, also more unusual things like cerebral vasculitis. We also had a couple of cases of cerebral venous sinus thrombosis and subarachnoid hemorrhage. And then this other second big group, altered mental status, which we've used as a catch-all term here to include encephalitis, actual inflammation of the brain, whether due to infection or due to an autoimmune process, encephalopathy, diffuse dysfunction of the brain without specific evidence of brain inflammation, and then neuropsychiatric disorders. And then the third big, broad diagnostic group were peripheral disorders, largely Guillain-Barré syndrome and variants. And then looking at the age of the cases, overall, the age of the reported cases, shown here in orange, was similar to the ages reported by Public Health England for all cases with COVID. But if we look at the cerebrovascular disease group here in blue and the neuropsychiatric disease group here in orange, we can see that there's a bit of a dichotomy here, that really we're seeing older patients with COVID having strokes, and we're seeing younger patients with neuropsychiatric disorders. And actually the majority of these patients with neuropsychiatric disorders with COVID were under 60. Majority of the stroke patients were over 60. And really that was one of the main novel findings from this paper, that not only are we seeing vascular complications in unwell older people, which to some degree was expected, we're also getting new onset psychiatric problems associated with COVID in younger people, which was a slightly unexpected finding. So here's one case which I'll describe in more detail because I think it sheds some light on biology what may be special about COVID. So this is a young woman in Southampton who developed an inflammatory CNS vasculopathy with antibodies against MOG, myelin oligodendrocyte glycoprotein, which came on about 1 week after the symptomatic onset of COVID infection. So this is an MRI of the brain, and you can see extensive T2, high T2 signal in the periventricular white matter, with here on the contrast-enhanced T1 scan, marked perivascular enhancement, which is quite an unusual pattern. And the CSF in this patient showed a cellular inflammatory response, but importantly, the PCR in the CSF was negative for coronavirus twice. This wasn't a syndrome of coronavirus infecting the brain. This was an inflammatory process. Here's the progression of the case after a week, and here's a dramatic response radiologically after the patient had steroids, immunosuppression, complete removal of the perivascular enhancement, and the patient actually made quite a dramatic clinical improvement. So our hypothesis in this case is that this was a double whammy, which may be quite unique to COVID, that the virus may bind to ACE2 receptors and infect the cerebral endothelium, causing a leaky blood-brain barrier. And then the secondary autoimmune response leading to a humoral immune response, in this case, MOG antibodies, can then enter the CNS across this leaky blood-brain barrier. So this might be an example where this particular virus's ability to initiate autoimmunity and to cause a vasculopathy might actually be synergistic in the pathophysiology. So I'm going to stop presenting data here, and I'm going to say a bit about why I think we actually need a big dose of caution interpreting this data, and also the flood of data coming in from all around the world. Because what might be said here is that, slow down, there isn't actually anything new here. We already know, like we've said, that there are neurological features of systemic infection. We already know that some of these are common, like delirium. And we already know that some of these are rare. And we already know that many viruses can be neurotropic, but that doesn't mean it's the mechanism in the vast majority of cases where neurological complications are probably immune mediated. And to that, I'd say I agree. I think that is important, and I think it is important to have a healthy dose of skepticism about this data. And of course, the big thing here is that this data is very vulnerable to ascertainment bias. There's probably huge underreporting. We don't think for a second that every patient who had a neurological complication of COVID in that time window was reported. But there could also be huge over-reporting. We're all human, that we have a bias to remembering cases which we think are interesting and reporting those. So there could be a bias there. And this is just an example, which I won't say where it came from, but something which I read in the media saying that ADEM appears to be increasing in prevalence due to the pandemic. I think we need to be really careful about avoiding jumping to conclusions like this, because identifying some cases of ADEM associated with COVID is not the same as proving that ADEM is increasing in prevalence. That needs quite robust epidemiological data to be able to prove that statement. And I think it's quite dangerous to make statements like this without good evidence, because it can create panic. In fact, here's quite an excellent paper which has just come out in preprint form, which is a proper epidemiological study looking at the incidence of GBS during the pandemic, which has shown that it's actually gone down, that actually there's less GBS at this time compared to matched data from previous years. So we've reported associations with COVID, but it's a big step from association to causation. And we've written another paper about this because I think it's really important that we need to be rigorous about proving causation in this case, in these cases. So this data is just the tip of the iceberg. The data that was in the paper included 153 cases. Actually, now I can tell you that we've had more than about 600 cases reported. Obviously, the overall cases of COVID, new infections are reducing in the country. It's difficult to know what's going to happen in the coming months. What we're going to do now, and I'll talk about this more in the next steps, is really drill down into each of these cases to see if we can unpick some of these question marks. So, I mean, what's going to happen with COVID? We're not going to eradicate or eliminate this virus. More likely, it seems this virus is going to be added to that list I showed at the beginning of circulating human coronaviruses. And that makes it more important that we have a really good handle on what the neurological manifestations are of this virus, both in the short and long term. So we're moving to the next phase of data collection. We're still getting rapid responses coming in, but we're moving to a more detailed case reporting form online, which collects full information on every case, the symptoms, both respiratory and neurological, the evolution of symptoms, investigation results, outcomes, and we'll still be analysing this data and publishing our next paper with the results of that. So here's what I see as our priorities for research in this field. We really need to find the denominator, how many people could have experienced neurological complications of those who did. Unless we have a really good handle on this, we won't know what the frequency of neurological complications is. And unless we know that, we can't really have a meaningful discussion about how important this is. Some modelling data from Imperial, which you might have seen, predicts that maybe up to 1.6 million people in the UK have been infected so far. But the obvious question there is that a big number? I mean, if you put that in context, and if you look at the modelling data for seasonal flu cases per year, that's somewhere in the region of maybe 12 million people per year infected with seasonal flu. And of course, we do sometimes see neurological complications of flu, but only in a very tiny fraction of that. For example, in a 2-year surveillance program for neurological complications of flu, there were 25 cases reported in 2 years, with only 4 in adults. So obviously any surveillance program can't be comprehensive, but there are ways that we can model the population, try and fill in that missing data. For example, using recapture analysis. Unless we get this data and put it out there, I think the void will be filled by speculation, like, for example, the ADEM story that I said. The only decent data that I've seen in this area, as well as that GBS paper that I mentioned that's just come out, is for stroke. There have actually been 2 studies now, one from Spain, one from the US, looking at an unselected cohort of inpatients with COVID and reporting the prevalence of stroke. And both have actually given a similar rate, which is about 1.5% of inpatients with COVID suffering a stroke. Now that's interesting because that is a big number. That is actually much higher than the known rate for influenza, which is about 0.2%. So, like I say, so far, I think the evidence that is coming about the stroke story seems to be supporting the idea that there may be a link with COVID. So I think the second big thing we need to do is unpick this stroke story, because I think it's important. It's the disorder where we've had the most signal with an association, and where we've had many biologically plausible hypotheses to explain causation, whether that be because there's a vasculopathy, whether that be because there's a coagulopathy. We need to unpick this, and what we need for that is better epidemiological data, controlling for co-founders. We need to know what the comorbidities of these patients suffering strokes are. We need to know other things, are people unwell with COVID stopping taking their antiplatelets? Simple things like these could be important co-founders. And we need to study the possible mechanisms, and we need to think not just in the brain, but also in the rest of the vasculature and in the heart. Cardioembolism could be an important source of stroke during COVID. So we need to think about mechanisms for stroke and for all of the neurological complications more broadly. And we've already got hints as to what pathways might be relevant. And as I showed you in that vasculopathy and MOG case, some of these mechanisms may be synergistic. I mentioned neurotropism last here because my feeling is that that's probably going to be the least important mechanism overall. We need to look at the impacts of treatments. Obviously, we've had good data now from the recovery study on dexamethasone for COVID, and because many of the neurological complications may be immune-mediated, the widespread use of dexamethasone is likely going to have a big impact on the rate and manifestations of neurological disorders with COVID. And there's some data for remdesivir, and that's now being widely used. That may also be altering neurological presentations. And TPA, tissue plasminogen activator, which is widely used as a treatment for acute ischemic stroke. Given this signal that there may be a vasculopathy going on in COVID, I think it's important to examine the complications of TPA in people having strokes associated with COVID, whether, for example, the rate of hemorrhagic transformation may be different in these patients. And then I think the last two things which I think are important to look into in the future are, we're already seeing large groups of people who are reporting persistent fatigue and other symptoms with a symptom complex similar to that seen in chronic fatigue syndrome. Obviously that can happen with any viral infection, but the difference here is scale. So I think we need to approach this with a really open mind. And I said at the beginning that one thing that we've done from the start was bring together neurology and psychiatry. And I think that's important here. I think we need to look at both biological and psychological factors and the interplay between them. And then finally, functional symptoms. We didn't record any cases of functional symptoms in our case series so far. But, you know, this is a difficult disease and it's a difficult time for the country and the world as a whole. And I think for many people, this pandemic may bring their first experience of functional neurological symptoms. And I think this is something that we as neurologists need to engage with and try and modify early on. And I think the best way of doing that is with more data. So that's all I wanted to say. Thanks very much for your time. Here's the Coroner Studies Management Group, which, like I say, involves many people from many universities across the UK and many professional societies and organisations without whom this wouldn't have been possible. Thank you very much.
Thank you so much. That was super comprehensive. I think we're just going to go kick off with a Q&A now. Oh, it's my face. Oh, God. This is strange. It's like looking in a mirror. Can you please stop the share screen? It's like a horrible laggy mirror. Thank you. Okay, so thank you so much. I think we'll kick off the Q&A. I'm going to start with a question, and hopefully that will kick off a few more being put in the Zoom chat, and we've also got a few on our social media as well. So the first question I wanted to ask was, you obviously talked about COVID's ability to kind of target ACE2 receptors. So I was wondering if you had any specific data looking at patients who were on ARBs, who were on you know, ACE inhibitors. Was there any difference there, or if you not looked at that?
Well, we have that data, but we've not looked at it yet. So in the case reporting forms, which are now being filled out in the next phase of data collection, we've got really comprehensive data on for all of these patients, which is now 600 plus. Not just the minimum data set, which I showed you here, but full data, all the medications they were taking, what medications were started in hospital, their outcomes. So yeah, I think that question will be much better placed to answer that question.
Okay,
and that's something we ask specifically, because whenever you're doing something like this, you know, if you ask a busy doctor to fill in what medications was this patient taking, sometimes, you know, it's difficult for busy doctors to be able to fill that out. So you've hit the nail on the head. That was a specific question we asked. Was this patient taking an ACE inhibitor or A2RP? Okay.
And was there any point, like during the treatment plan, where ACE inhibitors were even, or ARBs have thought about even, you know, starting them? Is there any evidence for, like, current evidence out there for the fact that they may benefit in COVID or not?
I'm not aware of such evidence.
Okay. No, I was just asking.
Yeah. It's an interesting question, though. I mean, there's something like, if you look at clinical trials website and look at how many drugs are being tried for COVID, it's something like 700. You know, there's trials going on for many medications.
Okay. So I'll move away from my question now. So someone said, what concerns do you have about the possible complications that could arise from patients contracting COVID and the winter flu at the same time?
Yeah, that's very important, and that's going to be increasingly important, you know, as the months go by. One, because of the difficulties that people may have maintaining social distancing as winter comes along, which may, you know, affect the course of the COVID pandemic. But then co-infection with influenza, you know, that could make respiratory disease worse. Like I mentioned, there is data showing that stroke is more common in the context of any systemic infection. It's more common in flu. There was that data showing that about 0.2% of inpatients with flu have a stroke. And there's now some good data showing that it's more common with COVID. So you would think that if there's a double whammy of both, then that might make things worse.
Thank you for a great presentation. I'd like to ask if you could clarify a little more about the possible treatments for COVID and their likely neurological effects.
Well, I mean, there's only one treatment so far that's been shown in a randomized control trial to be effective for COVID, and that's dexamethasone, which is obviously being widely used. And I mean, that's a steroid which penetrates the central nervous system. We use it, right? We use it for reducing swelling in the brain in any number of conditions. And given that many of the neurological complications of COVID may involve neuroinflammation, it's plausible that dexamethasone, whether given for that purpose or whether given to suppress the systemic response, may actually have a beneficial impact on neurological complications of COVID. So we may see, because basically there's been a switch right now. Previously, nobody would have got dexamethasone. Now, the first thing that happens when you come into hospital with COVID is you'd receive dexamethasone. So we may see a shift in the complications we see. It may be that complications due to neuroinflammation become less common than they were before. Correspondingly, that may mean that the signal we get about complications due to neuroinfection might actually come out more. It seems like that's going to be rare, cases where COVID, the virus, actually infects the brain. But we may see the balance switch because now we're in an era where everyone's receiving dexamethasone. And then there's remdesivir, which is still data still being accumulated, but we've had some evidence to suggest it is beneficial and it is being widely used. That now it's being widely used may also impact neurological manifestations because reducing the viral load may reduce the amount of circulating virus able to either enter the CNS or to stimulate an immune response. So in this now treatment era of COVID, where everyone coming into the hospital with COVID is getting a treatment, we may see a shift in the complications we see.
Right. So psychiatric symptoms were more common in younger patients than over 60s. Was there any trend or variation in the type of psychiatric problem?
Yeah, there were a couple of big groups within the psychiatric cases reported, mainly in younger people. There was a big group of cases with psychosis, which is fascinating. I mean, psychosis is a fascinating condition. I think it's a condition which exemplifies why artificially separating neurology and psychiatry is ridiculous, because many of the features of psychosis, you would clearly say, well, why should this fall into the remit of psychiatry rather than neurology? And obviously we see psychosis as a feature of conditions like encephalitis, for example. And there's been much discussion recently about how psychosis may be immune mediated. Not talking about COVID in general, about how psychosis may be immune mediated and how immunosuppressive treatments may be beneficial for psychosis. So I think it's really interesting that we saw this, I think it was 10 cases of psychosis that were reported to us in this COVID cohort. We saw affective disorders, depression, mania, as you might expect. There were 2, I think, but more now, cases of catatonia. Catatonia, again, a really fascinating condition which we call psychiatric, but could easily be called neurological. And I think catatonia is particularly interesting because catatonia has many overlaps with a movement disorder. The waxy flexibility and the lack of movement that you see in catatonia has much overlap with movement disorders. And if you look at the literature on encephalitis lethargica from 100 years ago, catatonia was quite a prominent feature of what was then called catatonia. It was quite a prominent feature of encephalitis lethargica. So that union between neurology and psychiatry is really important so that we can look at these cases from both angles. And we need to use the tools that both groups of us are accustomed to using in both these sets. So, what I'm really interested in seeing, for example, is brain imaging in these people who have experienced psychosis and catatonia.
And when you're discussing patients perhaps at like an NDT, where you may have seen kind of psychological symptoms, are psychiatrists involved in that, or is it mainly just the neurologists, or are they brought into NDT meetings?
I'm sure I think there's a lot of variation in different sectors, but we get on. So it's nice to work together, and that should only be encouraged more and more.
Thanks, really enjoyed the talk. Did you split strokes into, oh wait, yeah, you did split strokes into hemorrhagic and ischemic. I've seen
overall there were
saying,
more ischemic strokes. So you could debate the mechanisms for that, whether that's because of a coagulopathy making you more prone to clotting, whether that's because of arrhythmias causing cardioembolism, whether that's because of a myocarditis causing cardioembolism, whether that's because of some complete confounder, like people are ill and they don't take their aspirin and then they have a clot. But then we did also see some cases of hemorrhagic stroke. The majority were ischemic though.
I think his second part of the question actually asks, if blood clots, for example, cause problems with COVID, is that actually a neurological complication then? Could we class it under neuro?
I mean, anything within the brain we call ours, but what we call the brain is also the brain's vasculature, like I said at the beginning, and many neurological diseases are neurovascular diseases, right? And COVID causes clots in other organs, not just in the brain. In the lung, pulmonary embolism is a relatively common complication of COVID. So it seems pretty plausible that there's going to be some overlap in mechanisms there. And really, what I'm talking about stroke, but really what we may be seeing is a multi-system, multi-organ vasculopathy that manifests in one way. Obviously, the brain. I mean, I would say this because I'm a neurologist, but obviously the brain is a bit special in that the brain is very sensitive to any kind of insult, right? And usually manifests symptoms much more readily than some other organs might.
Thank you for the presentation. What are the current, this kind of links, what are the current hypotheses for how COVID may cause a stroke? So I'm assuming, is that related to the embolus of the blood clot?
Yeah, I think you could divide those into conditions where there's a problem with the blood, where it's causing a coagulopathy, conditions where it's causing a problem with blood vessels, a vasculopathy, or conditions where it's causing a problem with the heart, causing cardioembolism, or confounding factors. Devil's advocate, maybe it's not causing stroke, maybe it's just that it manifests in people who are older, have diabetes, have hypertension, which are risk factors for stroke. The thing that goes against that is that data I showed you from Spain and the US, suggesting that the rate of stroke in COVID is higher than it is with influenza, for example.
It might be interesting, obviously when you do have the seasonal flu come in, and you have this kind of another systemic illness coming in, it may be interesting to see if maybe coagulopathies become more predominant, those kind of symptoms, if you think that you've got a full systemic illness going on. There could be some interesting things there as well.
Yeah, exactly. I mean, D-dimer has been looked at a lot as a marker of coagulopathy in COVID, and that's another bit of data that we're going to be collecting. So we'll be able to look at, was D-dimer very raised in these patients? Lupus anticoagulant is another one. I mean, you can get a lupus anticoagulant during any systemic infection, but is that occurring? There have been some cases reported of people with COVID and stroke who had a lupus anticoagulant. So it remains to be seen whether that's more widespread.
Great. Are we anticipating many COVID-19 patients suffering some kinds of brain damage and needing rehab, or there being a prevalence of mental health problems following the pandemic, specifically from having COVID-19?
Yeah, that's an excellent question and extremely important for service provision in the future, right? But the only way to answer that question is to know what the frequency is. So, at the moment, I can tell you from this data and from data that other people have shown that, yes, there are many neurological complications with COVID, and a proportion of those, are likely to need rehabilitation, like a proportion of people with strokes do, like a proportion of people with encephalitis do. Whether the outcomes are worse with COVID than they are without COVID is not yet clear. There's some hint that maybe the stroke outcomes might be worse, but that's not clear. And whether there's actually a spike in cases, whether these cases that are associated with COVID are more than would have occurred otherwise, we can't know, and we need to be careful about jumping to that conclusion. But the person who asked that question is very right. If that is the case, that's very important, and we need to know about it.
Thank you for a great presentation. I'm thinking of specializing in neurology. What is life like working as a neurologist? What made you choose neurology? So a non-COVID question.
That's a great question. I mean, what is life like as a neurologist? I mean, I think it's one of the most fascinating branches of medicine. Who knows what the brain does? I mean, nobody knows, right? Isn't it crazy that we work with an organ where we don't even know what it does? And the other fascinating thing about neurology is that interaction between the mind and the brain. You know, we deal with disorders that cross that barrier, which I think is really important. You know, and ultimately it's about making a difference to people who have neurological disorders, and I think that's something that is very fulfilling.
What do you think about the overlap with psychiatry and neurology then? Do you think that they should be, you know, classed as individual specialities as they are, or do you think that, you know, perhaps dual training in neurology / psych is a thing in the future?
It's definitely a thing in the future. I think the separation between the two is a 20th century thing. It wasn't the case before. Mm-hmm. It was the case in the 20th century. It's becoming less the case now. Obviously, you know, there are different skill sets there, right? Psychiatrists are obviously hugely skilled in making a diagnostic formulation, in listening to symptoms, in psychological treatments. But they also, you know, do brain scans, prescribe medications, monitor complicated medications. We obviously, you know, are skilled in clinical examination, you know, and, you know, we do investigations, but we also deal with psychiatric problems. So that it's difficult to spread them up, difficult to split them apart. Mm-hmm. And I think they will only become more joined as time goes by. And I think it's really important, especially if there's anyone here who is a psychiatrist who wants to be a psychiatrist, to say that shouldn't be one way. It shouldn't be like, oh, well, we've discovered that this psychiatric illness that we used to call psychiatric actually is associated with this antibody. Oh, right, therefore it's now owned by neurologists. It shouldn't be that way. It should be a joining.
Yeah, like a hybrid. Okay, we'll go back onto the science. I think more people are asking questions. In patients with GBS, were any particular antiganglioside antibody associations or variants more predominant?
Yeah, that's a fascinating question and one that's being looked at. And Simon Rinaldi in Oxford and Michael Allen in London are looking at this very question as to whether there is, like with Miller-Fisher syndrome and anti-GQ1B antibodies, whether there's a specific antibody that might be associated with COVID-associated GBS. Don't know yet. Interesting question. I mean, to the person who asked that question, I wonder why do you think that's important? Do you think it's important because it might influence the treatment? Or do you think it's important because it might influence the outcome? I mean, the data I showed from that paper by Stephen Keddy, the preprint, suggested that GBS was actually less common at the moment than it was pre-COVID. There's all sorts of interesting reasons why that might be. In the paper, they suggested that maybe it was because Campylobacter transmission was less because everyone was social distancing. Campylobacter is obviously a common cause of GBS. So remains to be seen.
Very interesting, actually. Any theories as to why neuropsychiatric conditions were more common in under 60s?
Yeah, well, one theory, sort of the devil's advocate theory, would be that was ascertainment bias, that younger people might be more likely to access services, more likely to present, that the new onset of a psychiatric disease in a younger person, or that the new onset of a mental health disorder in a younger person would be more easily attributed to a psychiatric disorder than in an older person where it might be more quickly labeled as delirium, for example. So that's a sort of devil's advocate viewpoint, that somebody might say that. And of course that could be true. We'll only know the answer to that when we drill down into the data deeper. The other reason, the biological reason, is that, you know, we've all experienced sickness behavior, right? We've all experienced a systemic infection. Maybe we had flu or a cold, and we had some features of sickness behavior. We felt tired, we felt irritable, we wanted to sleep, we couldn't concentrate. That's sickness behavior. and we've all experienced that. And that occurs along a spectrum, right? And sometimes it occurs due to an systemic inflammatory insult, which isn't clear. And there have been loads of studies now. I recommend everyone read the book by Ed Bullmore, The Inflamed Mind, which looks at how inflammation can be a feature of treatment-resistant depression and how treating the inflammation can actually treat the depression. So it may be that what we're seeing is that some people are more prone to it because they, genetically or whatever, are hardwired to have kind of aberrant immune response, which may be prolonged. That might cause this sickness behavior. It might be that younger people's brains are wired in such a way that they're more likely to develop these rather than other complications. But yeah, interesting. Also, the younger cohort is likely to have less incipient neurodegenerative disease, whereas the older cohort, even if these are people who don't have a diagnosis of dementia, are going to have more undiagnosed neurodegenerative disease, which is going to modify the presentation.
Is that going to be then in the notes of the next data? And also, would you predict that maybe for more elderly patients that are coming, having these psychological symptoms, would there be some change in their psychological symptoms from COVID? Would they be, even ones that have already got psychological symptoms before, do you think that they could change?
It's difficult to say. I mean, and it's difficult to say because of, making new onset psychiatric diagnoses can sometimes be more difficult in older people than it is in younger people. So it's difficult to say. I think that's a question that'll be answered as more data comes in.
Great.
Also, the other biological reason may be as simple as, well, younger people aren't getting other stuff, so the psychiatric stuff becomes more prominent, right? That younger people without other risk factors for stroke, or for example, aren't getting strokes, so the other stuff is becoming clearer. It could just be that.
Was there a comparison of patients with different levels of respiratory support, particularly thinking NIV versus ventilated versus ECMO, and how that affects stroke?
In the next data. Yeah, that's really important because critical illness can be a risk factor for stroke, and invasive ventilation, is a massive strain on the system and can cause strain on the heart and can be associated with stroke, and same positive pressure non-invasive ventilation. So yeah, we're going to answer that question.
This might be a stupid question. People feel free to keep sending in more questions, but we've gotten to the bottom of the ones on the chat. Do you measure viral load for COVID?
Not all labs report it. We're collecting the data from PCR. Not all labs report it though, so not every patient. Some labs might report positive or negative, but we're collecting that data because we know. I mean, there's literature going back many decades to show that viral load during an infection is proportional to the immune response, which makes sense, right? More virus, more immune response. And it's likely that more immune response might mean more neurological complications, right? So yeah, viral load probably affects it. And that's why whoever asked about treatment, I think that's important, because if remdesivir does reduce viral load, then it might also have an impact on neurological complications in that way.
Another question, the final one I have, was there any difference in neurological features within the Black and minority ethnic populations?
Again, this is a very important question, and I think this is, I think this is a real top priority for us to answer in the next set of data, because we've got this data. I'm sitting on it right now, so that is an important question to answer, especially when we're looking at, hypertension, diabetes. These are comorbidities which are overrepresented in Black and Asian communities. So those are also risk factors for stroke, right? So we need to try and tease this apart. What is going on here? I think that's very important.
Another question, do you think COVID is going to become more prevalent once flu season comes about? I'm assuming this is a question about maybe synergy or making it more easy for it to get a COVID infection.
Yeah, I mean, I suppose that's a question for an epidemiologist, but I'm sure everyone feels like, we as a country have been successful in reducing the number of cases. That's great. Have we done that through a combination of measures, but including social distancing? Social distancing is going to become more hard in the winter. 1, 2, seasonal flu is going to circulate like it does every year. The seasonal flu pandemic might be slightly modified by the changes that have happened in everyone's behavior and in the circulation of another competing respiratory virus. But yeah, it's going to happen, isn't it?
I have another question here. Were there any unique features of encephalitis when it's caused by COVID?
The number of cases was small. There were some cases, there was one case published which had a temporal lobe encephalitis, which is quite typical in herpes simplex encephalitis. And that is interesting because then it makes you think, could it have been a trans-olfactory spread of the virus? Could it have been in the nasal mucosa, travelled up the olfactory nerve, through the cribriform plate, entered the temporal lobes? Which is interesting on many levels. One, that's a spread of the virus, which is not bloodborne, so it doesn't depend on ACE2 receptors or anything else we were talking about. And also relevant because of all these reports of anosmia.
Yeah, I was going to ask that, yeah.
Makes people think, is anosmia due to presence of the virus in the olfactory nerves? It's difficult to say. It's clearly not a huge phenomenon, right? Even without having the high quality epidemiological data that I'm talking about. I think it would be, it'd be hugely surprising if it ended up being that was the case in a large proportion of people with COVID, because it clearly isn't. We had 7 cases reported. There have been 3 full cases or 2 full cases reported worldwide. It seems unlikely that, and there's probably been millions of people infected with COVID in the UK. So it seems unlikely that it's the case in everybody. Is it a case in a small subset of people who, for whatever reason, have some vulnerability? Yeah, it might be. I mean, other things that we saw were a hemorrhagic encephalitis, which could be that there's breakdown of the blood-brain barrier, breakdown of blood vessels as part of this necrotizing encephalitis, causing bleeding. So nothing that you could say is pathognomonic, that you would look at a brain scan and go, this must be COVID encephalitis, because no one's yet defined an entity of COVID encephalitis because there have been so few cases reported, and it may be that it isn't a defined syndrome.
Okay, great. Well, I think I haven't received any other questions, so we might let you go now. I think that's it from everyone. But thank you so much for taking the time to come talk to us.
You're very welcome. Thanks for the invite.
Yeah, and all the best. Okay, I'll just end the meeting. But thanks so much to everyone for coming.
Thank you.
Okay, great. Bye-bye.